So the today's topic is diabetic cardiac steatosis. So Dr. Vinit, the screen, you can see the screen, right?
Yeah, it's visible.
Okay, thank you. Yeah. So the growing interest has been accumulated in the definition of worsening of effect of diabetes in cardiovascular system. And this is associated with epidemiological data regarding higher incidence of heart failure in diabetic patients. To investigate the decremental effect of both hyperglycemia and insulin resistance, a lot of preclinical models were developed. However, the evidence of pathogenic and histological alteration of the so-called diabetic cardiomyopathy. So we are concentrating today on this particular topic. There are several stress factors which can stressors which can cause diabetic cardiomyopathy. It can be divided as metabolic stressors and biochemical stressors, which leads to metabolic injury as a result of this developed diabetic cardiomyopathy. So in case of this metabolic remodeling, because of the hyperglycemia, oxidative stress, ages, mitochondrial dysfunction, abnormal calcium homeostasis, and free fatty acid metabolism. And all these things happens in diabetes, and because of this, there can be microvascular dysfunction and metabolic remodeling happens. And due to this subclinical remodeling, there can be inflammation, extracellular matrix alteration, diastolic dysfunction sets in. All these stressors and factors which can lead to heart failure, and we named it as diabetic cardiomyopathy. In a diabetic cardiomyopathy, as we already discussed, due to this insulin resistance and hyperglycemia, there are several factors which contribute these things, like impaired calcium handling, lipotoxicity, the advanced glycation end products, which we called as age or ages, the increased oxidative stress, increased free fatty acid utilization, and fibrosis sets in, which can cause this diabetic cardiomyopathy. At the same time, there can be the endoplasmic reticulum stress, mitochondrial dysfunction, RAS impairment, essential impairment, microvascular dysfunction. So all these factors can affect the heart and ultimately sets into diabetic cardiomyopathy. And because of this diabetes, as we already discussed, this the effects of hyperinsulinemia, insulin resistance, and hyperglycemia, there will be inflammation, dyslipidemia, and endothelial dysfunction. All these three things can cause coronary artery disease and ultimately sets in ischemic cardiomyopathy and develops the diabetic cardiomyopathy. On the other side, there can be cardiomyocyte hypertrophy. RAS activation can cause this thing, and there is an impaired calcium handling or autonomous dysfunction, which all these things can cause fibrosis and ultimately sets into diabetic cardiomyopathy, and heart failure sets in diabetes. So the excessive free fatty acid delivery, in the setting of this excessive free fatty when it is associated with obesity and type 2 diabetes, the free fatty acid uptake can, by the cardiac myocytes exceeds the mitochondrial oxidative capacity, which may be additionally impaired by several putative mechanisms. The resultant lipid storage, the over storage, which is called cardiac steatosis, produces lipotoxic intermediates such as ceramide and increased production of reactive oxygen species we call as ROS, which causes apoptosis. The combination of this increased free fatty acid delivery to cardiomyocytes seen in obesity and type 2 diabetes, coupled with impaired fatty acid oxidation seen in heart failure, leads to myocardial steatosis. So there are several stages of diabetic cardiomyopathy. In the stage 1, there is a diastolic dysfunction. In stage 2, there will be systolic and diastolic dysfunction. In stage 3, there will be an association of the systolic and diastolic dysfunction with microvascular diseases and coronary atherosclerosis. And stage 4 is overt ischemia and causing heart failure. So the pathological mechanisms we already discussed. So these are the 4 stages you can see in diabetic cardiomyopathy. For diagnosing this particular diabetic cardiomyopathy, we can use cardiac MRI. So the left ventricular diastolic dysfunction can be assessed using the flow velocity encoded cardiac MRI. Using cardiac MRI, the myocardial diastolic functional parameters have been shown to associate with myocardial triglyceride accumulation in healthy volunteers. The lipid staining was also seen in obese and type 2 diabetes patients with end-stage heart failure. So the magnetic resonance spectroscopy, you can see in this spectroscopy, the dark gray areas which is the cardiac muscles, and the white areas which can be the blood or the pericardial fat. And this is the volume testing for myocardial triglyceride content is placed, and you can see in this graph the tissue metabolites, how it comes, and the myocardial triglycerides. So this is the one method which by which we can diagnose cardiac steatosis, or so-called diabetic cardiomyopathy, or increased triglyceride content in the heart muscles. So in addition to this myocardial accumulation of triglycerides in type 2 diabetes, there will be increased visceral adipose tissues which associate with the elevation of circulating plasma triglycerides and non-esterified fatty acids, and contributes to lipid overexposure to non-adipose tissue compartments. So the excessive triglyceride storage enters into a continuous cycle between hydrolysis and fatty acid re-esterification, yielding to cardiotoxic intermediates such as ceramide and diglycerol, which seems to be an important route leading to myocardial dysfunction. So here, basically, we are going to talk about reactive oxygen species and what is the role of the particular treatment for the to encounter this diabetic cardiomyopathy. So the oxidative stress, defined as an imbalance of reactive oxygen species, has increasingly proposed to contribute to the development of diabetic cardiomyopathy. The overproduction of ROS in diabetic cardiomyopathy is thought to be counterbalanced by the elevated antioxidant defense mechanisms such as catalase and superoxide dismutase. The excessive ROS in cardiomyocytes result in further production of ROS in the mitochondrial DNA damage, lipid peroxidase, and cross-transitional modification of proteins, and ultimately cell death and cardiac dysfunction. So these are the pathological mechanisms happens when there is an increased reactive oxygen species. So these ROS modulate transcription factors are responsible for the expression of antioxidant enzymes. Lastly, the evidence exists that several pharmacological agents that convey the cardiovascular benefits by antioxidant mechanisms. So the pathway that leads to increased ROS production and impaired antioxidants defense may enable to the development of therapeutic strategies against this progression of diabetic cardiomyopathy. So this is what we were talking in the last slides. Because of the diabetes, there can be increased production of ROS. And so there are several drugs which are used in diabetes, like SGLT2, GPL1RA, DPP4, ARB. So these are the several drugs which can stop this increased, as well as the natural antioxidants and ROS scavengers can stop this increased production of ROS, and we can stop the further development of this mitochondrial dysfunction or myocardial hypertrophy, cell death, fibrosis, and contractile dysfunction, and ultimately sets into this diabetic cardiomyopathy. So pioglitazone, such a drug, a peroxisome proliferator activator receptor gamma agonist, which has the capacity to divert fat from non-adipose tissues to subcutaneous tissue, has shown to lower the myocardial triglyceride content in diabetic patients on an insulin-based treatment regimen. And therefore, the myocardial triglyceride may be a useful indicator of myocardial cardiac steatosis for predicting the severity of diabetic cardiomyopathy and for evaluating the effects of anti-steatotic therapy. So these are a few studies done by our team you can see the impact of diabetes on mortality and rehospitalization in acute heart failure patients stratified by the ejection fraction. It was published in ESC Heart Failure Journal during 2020. We found that there was no significant difference in 3 months and 12 months all-cause mortality, as well as the rehospitalization rates between the diabetic and non-diabetic patients in all the 3 heart failure groups stratified by left ventricular ejection fraction. Also, another study we published in Oman Medical Journal during 2020. The mortality and morbidity in heart failure with reduced ejection fraction, mid-range, and preserved ejection fraction in patients with diabetes in the Middle East. And we found that there is a 3-month cumulative all-cause mortality was high in diabetic patients with reduced ejection fraction when compared to those with the preserved ejection fraction. So thank you very much. If there is any questions, most welcome. Over to Dr. Vineet.
Thank you. Thank you so much, Dr. Rajesh. Any questions for Dr. Rajesh? Any questions for Dr. Rajesh?
So if there is no questions, thank you very much, Dr. Vineet. I have to go for OPD in the middle of work. Thank you very much for inviting.
Thank you. Thank you so much. I request Dr. Rajesh to kindly withdraw his slides. That was a wonderful presentation, Dr. Rajesh. Very lucid, very brisk. Thank you so much.
Yeah, thank you. Thank you, Dr. Vineet.